Welcome to the Startup Club podcast, where we share the journeys of invention, failure, resilience, and triumph of some of South Africa's top tech startup founders and investors. I'm Matthew Marsden, founder of Startup Club ZA, and on the show today, Saul Kornik, co-founder and CEO of Healthforce and Kena Health, the technology ventures solving the gap in the country's health infrastructure by making affordable care accessible to hundreds of thousands of patients across the budget spectrum. Now, both ventures have achieved significant milestones, with Healthforce facilitating over 3.6 million nurse consults since inception in 2018, and Kena Health raising both significant venture capital and corporate backing and winning the MTN Business App of the Year award in 2023. But, as you'll hear in today's episode, it's clear that things are only just getting started for Saul on his mission to make healthcare available to millions of people across the country.
But really at the heart of the problem of expenses in the private healthcare sector is fee-for-service, which is a model where you pay a provider. The provider might be a doctor or a nurse or a hospital. You pay the provider for delivering a service, not for delivering an outcome. Nowhere else does this happen.
While access to healthcare is a constitutional right in South Africa, Bloomberg estimates that nearly 85% of the nation's 62 million people have no medical insurance and rely on the free treatment public system, itself facing shortages in funding, medicine, and medical personnel. It's also estimated that the high cost of quality healthcare, with medical scheme premiums rising rapidly year on year, is locking 85% of citizens out of the private sector. Now, Parliament has recently approved a controversial legislation for the rollout of national health insurance to be phased in over several years. However, doubts do remain about whether it will be able to solve the country's healthcare woes and on whom the ultimate cost burden will fall. In the interim, however, there has been an encouraging wave of innovative startups creating solutions to address the healthcare gap. And among the frontrunners are Healthforce and Kena Health, respectively. Now, Healthforce offers a clinic management software that, among other capabilities, sets up clinic nurses as the low-cost entry point into the healthcare system, whilst Kena is an app that lowers the cost of care by enabling users to speak to a nurse, doctor, or mental health professional on their mobile device. Both ventures have achieved significant milestones, although they're both getting started. Saul Kornik was born and raised in Cape Town, South Africa in the late 1970s and grew up in the early 80s. His father was a doctor and his mother was self-employed. After finishing his finance and accounting studies in 2003, as well as his CFA, he was seemingly destined for a career in the world of London-based investment banking, until in 2005, when something significant happened that would change the trajectory of his life forever.
Yeah, that's quite an interesting question. I've got two brothers. I think they're probably foundational to the way I look at the world. We kind of socialized, either spent time negotiating around toys and games and strange forts we built in the garden. So I'd say they've obviously a very core part of my upbringing, and I'm still very close with them today. They're great people.
Sure.
Who actually, one of them started a business himself, and the other's also involved in the business environment. So there was obviously something in the water in our household. And then, both of our parents, although my dad is a doctor, both of them were entrepreneurially inclined. They were always between them starting things and trying things out and running businesses of different kinds. And then I think I went to a really awesome school, which was quite encouraged an open mind with respect to how one views society, and provided a lot of autonomy to its students. Jokes in the school about how many committees they were run by different students, and I suppose that kind of suited my personality, where I could get involved in a lot of different things.
Were you, what kind of personality did you have? Were you an extrovert? Were you very enterprising? Were there instances where you set up a stall on the side of the road, or try to start these micro businesses, or took up the market opportunities? What was there an entrepreneur in young Saul? Is the question.
When I wanted to buy I remember when I was in junior school and I wanted to buy a toy, then we had to become pretty entrepreneurial.
Sure.
I think my younger brother and myself went around washing people's cars in the neighborhood to save up when we were still well less than 10. And later in school, I suppose I was just really always been quite hardworking and quite focused when I needed to get down to things.
Okay. And so you go to school at Westerford High School in Cape Town. And if I had to ask you, what kind of student were you? You strike me as studious, and just based on the answer you've already given me, it would suggest that you would knuckle down when the time called for it. But were you a good student?
A good student.
Well,
we need to define good.
Yes, okay. In the
I,
traditional academic sense.
Well, I mean, rather say, like, actually, as opposed to some people, I feel quite sad for them. I quite enjoyed school. I never really felt like I was aligned with any particular group. I had friends from various groups across the school, and always enjoyed lots of different kinds of personalities and lots of different kinds of interests. So I was fortunate. In that way. And as I said, when I put my head down,
Sure.
and I got stuff done.
Yeah,
and
sure.
That's just how I am.
Sure, and we'll see a number of, instances of that in some of the details we discussed today. Notwithstanding studies and qualifications and things like that. But before we get there, I'm always curious, and this is maybe more of a fun question. When you were growing up, was there something you were adamant you wanted to be? Some folks want to be a doctor, a fireman, lawyer. What did
I wanted to build a space rocket that went to Mars.
Oh, there we go.
Yeah, I used to sit in class drawing it. I used to take books out of the library to learn how to design it. I actually had, top of my cupboard was filled with books from aeronautical engineering schools around the world. Okay. That's really what I wanted to do.
Are we on track? So what's
maybe. I don't know. I haven't given up on it yet.
Yes. Very fair. You finished school in 95, and you choose to study at the University of Cape Town. Now, of course, the rocket scientist or perhaps engineer in you, you didn't go the engineering route. You studied business science, and maybe talk to us. What was the thinking there? Was it just a generalist degree? Were you unsure what you might pivot into thereafter, or was it just a good foundation?
I don't think any 17-year-old really knows what they're doing.
Even computes.
Yes, yeah, okay, and I don't think I knew what I was really doing, and happened upon it, and put my head down and took what I could from it and got it done and made friends and had a good experience, and then it's kind of suppose what I've learned there has stood me in good stead for some of the stuff I've done subsequently.
Sure. You initially study a business science honors in finance. You also graduate with a BCom honors in accounting. And then I see 2001, you endeavor to do your master's degree in AI and corporate failure. Now, again, at the time, artificial intelligence is not even a word people dare to mention, perhaps, for fear of what might happen, Terminator, Skynet, and otherwise. What compels one in your early 20s to do a master's degree of that nature?
Well, at the time, it wasn't even called AI. I mean, there was definitely AI around, but the specific thesis that I did for that qualification was in machine learning. Okay. And I suppose it was just, I was always been interested in the engineering side of things, and I found a professor at UCT who was a genius and was very, really exceptional at explaining his genius. So I spent for a number of months, I spent time with him during lunchtimes, and he explained conceptually how these machine learning algorithms work. And then off the back of that, I taught myself a coding language and built one myself.
Amazing.
Turned that into a thesis.
And that's 3 years of your life. I think justifiably
like
so, right? Certainly a difficult thesis to undertake. Now, not that, for most people that would have been enough, it seems, but you go on to qualify as a CA and achieve your CFA at the same time. Yeah. Pretty remarkable.
I mean, there's a lot of overlap between those qualifications.
Sure.
So the experience I got during articles could apply both to CFA and CA. Sure. The finance qualification I'd done taught me a lot of stuff I needed for the CFA. So it felt at the time like I was just consolidating knowledge and setting myself up with qualifications that might be of value down the line.
You strike me as quite calculated. So even though maybe at a young
Calculated.
age
That sounds like $1 billion kind of calculated.
No, well, perhaps, I don't know. Maybe Kena, but I mean in the sense that things are strategic. You've plotted a lot as to where you are even today, which may not be the case as we go through your life story, ironically. But certainly, at least as an academic and qualification foundation, you seem to have started off certainly the right way. Now, given that you now have a master's degree, you've got your CFA, you are a CA, seemingly loads of options at your disposal. You decide in 2004 to join Goldman Sachs as an analyst in their London office. A little while ago, not too long ago, but any inclination, or maybe give us some insight into what was the thinking there? Was it the thing where a lot of the Saffers were thinking about London at the time, and it was kind of the trend, or did you have that, or was it a bit by design, perhaps, maybe?
Well, first of all, I mean, you mentioned at the start of that question that I did the right things, and sure. I must just say I don't know that I did the right things. Okay. I think in retrospect I might have done things, actually definitely would have done things completely differently. Yeah. But yeah, I had what I had. I wanted to get out into the world and see what I hadn't seen and experience what I didn't even know was out there. And yeah, at the time there was this visa which allowed us to go work, South Africans to go work in London for 2 years. I don't even know if it still exists. Sure. And when I got there, I needed to pay the bills. And in all honesty, I didn't target Goldman Sachs. A recruiter got me an interview there, and I got the appointment and didn't take it too seriously. I managed to pay the bills through the work and actually spent a lot more of my time playing water polo around the city with a really interesting group of guys from 6 different continents, and making friends and traveling from there to different places. But there was definitely something about the experience, that first work experience outside of South Africa, that I suppose showed me the way organizations can be structured, and the ways in which an organization, specifically like Goldman Sachs, can have such a tight culture that everyone really finds themselves doing things in a very similar way, and in strong alignment and strong lockstep. And I suppose that's one thing I took from that experience.
It's an interesting one. We've asked a number of founders who've been on the podcast, what advice would you give perhaps to students? A lot of them are studying. They wonder, I've got this idea for a startup. Should I go and start that immediately? And actually the general consensus is, even though you may not live in a corporate for the rest of your life, there is a lot of merit to joining for a year or two, just to understand corporate culture and systems thinking, and even best practice that have taken 50, 60 years to master. And I wonder if that wasn't the case maybe in your Goldman Sachs experience, just gleaning a little bit of those insights, helping you run organizations even to this day maybe.
Look, at the time I didn't think I was going to start any businesses. I didn't even know if I was going to be in business. And so I didn't go in there trying to learn how organizations work. I know other people that were wiser than I was when they were younger and did that. So I don't know. I mean, I think when you're young and you don't know what you're going to do, then, you can go into a place like that and learn nothing as well. And I suppose when I talk about the culture thing, I more just mean that there was a way of doing things there and I didn't feel like I fitted into it. Okay. And that was an experience to know that there was a bunch of people that really did fit in and were excelling there and were loving it, and yet I just didn't. And what I try and do, certainly with the organizations that I'm now involved in, is to make sure that there's a particular fit that allows us to deliver to our customers, and reminding myself that some people will fit and some people don't, and if they don't, they're not bad people, they just don't.
Can I ask, and again, you're at liberty to disclose what you like here, but do you think that was a value fit or a work ethic fit?
For Goldman Sachs?
For like a Goldman Sachs, which is, I guess, the poster child of most modern finance and investment banking institutions, right? Do you think it's more of a value fit, the why behind what we're doing and the way in which we do it, as opposed to what we do?
So actually, there was a lack of a value fit there for me. Eventually, I kind of started waking up a little bit and realizing that to live somebody else's story, the story of the Goldman Sachs directors, and to essentially make rich people richer, was not a story that was my story. Sure. And so I started thinking a little bit more independently and trying to figure out, without knowing at all what it was, like who am I and what's the right story for me.
It's a relatively short tenure at Goldman. You do join a different bank, Lloyd's TSB, the following year, 2005, essentially in their investment banking division. And again, not too long thereafter, and I'd love for you to expand on this, there's quite a significant change in your career, perhaps in your life or trajectory, maybe your view of what you want to do. And in 2006, you go on to co-found and become the CEO of Africa Health Placements. And I certainly don't want to steal your thunder, and maybe telling us a little bit about, what was the shift? Was there a moment that just inspired you to start this venture? And then we'll talk about the venture itself a little bit,
Sure,
if you don't mind expanding.
Yeah, and so I mean, I touched on it already. I just didn't feel like I fitted into the investment banking environment. Like I was always felt like a bit of an outsider, and it didn't feel, and it was never really grabbed by the work. And I was looking around for what to do, and I thought, okay, well, clearly I don't want to do stuff to, make wealthier people wealthier, like what an investment bank is really trying to do, allocate capital effectively. I thought, maybe more directly I can help people who don't have, or if I'm not going to do that, then I must help myself.
Sure.
And I'd grown up in quite a privileged position in society in South Africa, and quite a protected position. And so I took this view that, hey, let me see if I can help other people without knowing what that looked like. And I wasn't really married to health in particular.
Sure.
And then I've got a friend who was a doctor working in a rural area. He was doing his community service in the Eastern Cape at a hospital called Madweleni. And in between Goldman Sachs and Lloyd's, I did this funny trip I'm not going to get into, and he came and joined for a little bit of time and told me about a professor at UKZN who he knew, who was bringing rural doctors to some hospitals there, and he wanted to get involved, and it sounded interesting. So that just kind of took me down that path. I don't think I was ever particularly inspired to do something in healthcare. I don't think I'm ever particularly inspired, to be honest. I think I kind of looked at it and it made sense, and it looked like it could do something good, and it looked like it was scalable, and it looked like it needed some energy, and so decided to put my energy there.
Amazing. So maybe just walk us through the actual formation of what this venture would become. This was a non-profit. Yes, this was an NGO.
It started out as a non-profit.
Okay, started out as a non-profit, and really, at least from what I've read, the endeavor here is to get doctors placed where they are needed most, but then also to upskill them to ensure that they are more effective, have access to the right systems. And this venture goes on to place over 4,200 doctors over the lifetime in which you were there. I certainly don't want to skip over what is more than a decade of your life, because you do some significant things here, impact loads of people, whether that was the inspiration or not necessarily from the get-go. And we'll get into a couple of those details there, but maybe talk to us about, how do you carve out this? So you see there's a need. There are doctors who can be placed. There's places that need them. How do you go about structuring a venture around that?
Sure.
You also go on to raise some pretty significant funding for this endeavor. Maybe just walk us through what are the early days of that look like?
Well, the early days were very much a bunch of other people who knew what the need was, who had ideas about how to get things done, and I essentially played the role of saying, cool, I think this can be something that gets done at a much greater scale, and putting together the pieces that needed to allow that to happen.
Okay.
And I suppose the early days of that was me I'd never run an organization before, I'd never fundraised before, I knew absolutely nothing about healthcare, I knew nothing about placements and recruitment. So it was just asking a lot of questions and coming from a place where I just knew nothing. I really did know nothing. And I suppose it's really important to keep that mindset on an ongoing basis. So, managed to pull together some really good people, really passionate about what we were doing. And the team, grew from placing a couple of doctors in a couple of hospitals to placing in 6 different countries and placing thousands upon thousands. And then, we realized that it wasn't just good enough to place these guys. We also needed to know where they needed to go. So we started doing workforce planning, and then it wasn't good enough just to place them, but we also needed to keep them there for as long as possible. So we worked on retention. And over the years, the organization grew, and we partnered with some really awesome companies and had really the support of the rural doctor community to do so. And it became something significant where we worked very closely with government and successfully got healthcare workers to where they were needed. And really the underlying kind of driver behind that is the fact that if you look at Africa more broadly, it's got 25% of the global disease burden, but only 2% of the world's physicians. And this is kind of understandable when one considers what's called the inverse care law, which is something that Tudor Hart coined in the 70s. And the inverse care law basically says that doctors go to where they are needed the least. And it makes sense. A wealthy country can train more doctors and then retain them with higher salaries, but because they're wealthier, but they probably have fewer healthcare needs. Whereas a place like South Africa can train fewer doctors and struggles to retain them because it's a tough working environment. And so we have this brain drain, and we were essentially trying to reverse that. And there were very real positives in our favor that allowed us to do so. I mean, people were coming to work in Baragwanath here and saying it was the time of the Iraq War, and they were saying they were seeing more gunshot wounds at Baragwanath than they were seeing in a week here than they were seeing in a year in Iraq. So there was really awesome opportunities for global health experience, and at the same time these doctors were filling gaps that were very much needed in our healthcare system. And it's off the back of that, I suppose, product market fit that we were able to grow the business.
I think, again, we were spending a couple of minutes on this, but you found Africa Health Placements in 2006. You are the CEO of the business until 2017, so 11 years, and remain as chairman until 2020. Of course, there's a couple of interesting things that happen on leaving as CEO, and we'll get into those in a couple of seconds. This is something maybe that's harped on too much by founders these days, especially before they have a solution or even identify the problem they want to serve. But just wanted to talk to you a little bit about fundraising in the AHP context. You've raised some significant, several $1 million for this endeavor over that decade plus, and initially starts out as a non-profit. You have built 2 for-profit businesses now. What are the differences that you've seen in fundraising between those two? And especially you had some investment banking experience, but presumably no massive network of donors, sponsors, private equity. What was it like raising capital for this venture, Africa Health Placements, during the time in which you did?
It was significant experience. I mean, we raised probably in excess of, but there were tens of millions of dollars, if not $100 million that we eventually raised over the period of time that I was there. Some of it I did on my own, sometimes partnering with other companies to do so. But I suppose I got frustrated at some point. And the frustration was that the problem was massive. The business needed to scale to meet that need. The need was there. The supply from our position was there to meet that need, but the capital to do so was constrained by the availability of donor funding and, very frustratingly, whether donors thought what we were doing was valuable or not. And we knew what we were doing was valuable. And I mean, I suppose sometimes it didn't fit within the donor's mandate. Sometimes it just didn't understand what we were doing. And so I just realized that, I think there's definitely a world in which organizations need to be donor funded because there's no commercial model. But certainly if you want to scale something massively to solve a seemingly intractable problem, you're going to hit a limit with donor funding where you can't raise anymore, and actually spending most of your time just trying to keep yourself where you are, either satisfying current donors or trying to replace those that are leaving. So, I mean, that was one of the main reasons why I decided to leave AHP. We did convert it at some point into a social enterprise where we started charging doctors kind of a fee for the global health experience we were offering them. There was an opportunity to do that, but I think by that stage, It wasn't just the donor funding that was frustrating me. There were a number of other things that meant it was time for me personally, at least, to move on to other things.
Fair. Yeah, that's fair. There is, I'm going to quote another interview that you did, and you actually just mentioned here regarding the AFP model. It's actually quite hard running a laborious 18-month process to move doctors to rural Africa for a year. It's unscalable operationally and financially, relying on donors the entire time. And these doctors could only see a maximum of 25 patients a day. And why I mentioned that specifically is because I think that's a great segue for us to get into Healthforce, because this is the beauty of augmenting those solutions with technology, right? If the right folks can pioneer those things. Probably just worth mentioning in the context of your personal journey, you have 2 young kids today. They would have been born in and around this time, I imagine, yes? Were you married at this time, moving in and out of AFP? What was happening on the personal front, if we can quickly
When
touch on
Healthforce
that?
started?
Just in the context
End
of
of
all of
HP,
this.
start of Healthforce.
Yeah.
So I'd met Joe by that stage.
Okay.
And I suppose we're not married, but we're partners for life. And our eldest son was born just before I left AHP.
Okay.
Yeah, so there was a new family.
Yes. Just important context. A lot of founders are wondering, like, is there a right time? B, is the risk worth it if I've got these other people now?
But the reality is like I was never going to starve, right?
Sure.
So, I mean, what was the real risk? The real risk was one of failure. And what is failure? It didn't seem, I wasn't really scared of the failure aspect of it. It was worth something. It was worth trying, and the risks to me personally weren't particularly high if I needed to go and do work elsewhere. So,
yes, of course.
Didn't really feel like I was taking a big risk at the time.
Okay.
But certainly, if anything, it was just a very, I suppose a lot of things were starting up, and having a child is certainly much bigger than starting a startup.
It's a venture of its own.
Yeah, exactly. And first-time parents are always much more fastidious and wary of things that later on you kind of laugh about. But yeah, that was all happening at the same time.
Wow. And so quickly tell me, had you left 2018, you go about starting Healthforce, and we'll talk about how that came about. I think, again, speaking to some of the need that you've seen in a lot of the more physically intensive in-person operations of the AHP experience. But did you leave AHP first and there was this gap? Was it, what am I going to do next? Or did you have Healthforce kind of slowly brewing in the background and you were able to make that jump?
I actually started my transition out of AHP a couple of years before my final day there.
Okay.
I remember I never get sick. I just never get sick. And I got really sick and was actually in bed for a week or 2 weeks. Wow. And I realized at the time that my body was telling me, you're pushing yourself and doing something you don't really want to do anymore. And I remember as soon as I got better, I went off to the chairman of the board and I was like, okay, cool, I'm out. We've got to find a transition plan. And that transition plan kind of succeeded for a little bit and then failed. So I needed to step back in. And then, eventually it got to the point where, it was ready for me to go. And at that time, I knew someone I'd met and liked through my brother. And he was an investor at an investment house that was building out a chain of pharmacies around the country, small pharmacies. He was talking about how he wanted to use Skype to offer doctor services into one of his pharmacies, and we spoke about it and met a number of times about it and explored the idea together. And this, I think, overlapped with my time at AHP. And we spoke about, we just spoke about it, and it captured me, and the idea captured me, and I could see much more than, I suppose, I could see the bigger problem and how it could scale to solve a much bigger problem than where it was starting out. And that led to the kind of us forming Healthforce.
Amazing. Yeah, telemedicine is a bit more common practice these days. Most people will be familiar with this idea. It's not so foreign. But at the time, 5 years ago, it was still goodness, you're going to forego seeing your doctor in person. Like, why would you do that? But naturally, there's a budget consideration there for the majority of South Africans, and we'll touch on that in a second. Healthforce has quite an interesting angle when you launch it, in that you really are trying to give access to low-cost, affordable healthcare by enabling nurses. And I wanted you just to touch on that because, again, most founders go, I see this gap in the market, I'm going to come up with a solution to solve it. I think you've been quite intuitive, and I don't know many other businesses that are trying to approach it that way. And I guess the success you've had over recent years is a validation of that approach. But maybe just for the folks who are laymen or haven't necessarily understood more about the Healthforce proposition, what is that, and what is nurse-led telemedicine?
Sure.
Yeah,
sure. I'm happy to explain. The one thing just to say before I do explain it is the explanation I give now, 6 years after co-founding the business, is quite different to what I was thinking at the time.
Yes. So what were you thinking at the time? And,
at the time, I mean, it's an interesting question. I mean, you can only, like, these stories told after the fact are always clouded by what you know now.
Sure.
And they always sound like nice straight line stories where there was this grand vision and then you achieved it. And when I hear founders telling stories like that, I'm either impressed or in disbelief.
Yes.
Usually the latter.
Yes. Yes, sure.
Sure. So look, at the time it was a case of the very basic thing of, I suppose, let me frame it like this, off the back of the lessons I learned at AHP, which is that it's very, like, there's a shortage of doctors. It seemed inefficient in my mind for doctors to spend 30 minutes with a patient. Surely that all that time wasn't needed. And the other thing about it was just how long it took to get a doctor to where they were needed. I mean, to get a doctor to a community where there's no doctor is a big task. Moving them from overseas, as you mentioned, is taking 18 months. But even moving internally with South Africa, encouraging urban doctors to work in rural areas where there's a huge inequality in the distribution of doctors is a nearly impossible task. And so the idea with Healthforce was, first of all, could we use technology to move them instantaneously? And that's, I suppose, the telemedicine component, but also can we use their time more effectively? And so the idea right at the start was, let's see if we can, and the other thing to say is that when we looked around the country, we could see there was a lot of infrastructure that was underutilized when it came to healthcare delivery. And that infrastructure I'm talking about is 3,000 pharmacies around the country with nurses sitting in clinic rooms at the back, who are doing nothing at the time other than weighing babies and doing some vitality health checks. And really these nurses had been trained to do, proper primary care. And so the idea was, let's take these nurses, let's skill them back up to doing what they were originally trained to do. And we supercharge them through technology and make sure the technology facilitates them to do more. And not just the technology, but the way we use our own human team to coach them through that process of reskilling and coach them through the process of doing more in the pharmacy, but really with the ultimate goal at the end, where it's necessary, of being able to call a virtual doctor on demand when the patient so requires. And that's what our technology still to this day allows for, that nurses can do a lot more because the technology enables them to do a lot more. We've even got an e-learning platform that helps to scale them up. But when the nurse can't diagnose, she can't prescribe, she clicks a button, and without having made an appointment, one of our doctors will appear on a flat screen TV in the clinic room, on average 3 minutes later. Wow. The doctor can see the nurse and the patient and can see all the notes the nurse has captured, as well as all the historical times the patient has visited any one of our 550 clinics around the country. Wow. And then the nurse and doctor can work together to solve the problem for the patient, with the doctor providing a script, a referral letter, or a sick note. And the beauty of this is that, first of all, doesn't matter with the doctors. We've had doctors consulting from Kamchatka into rural pharmacies in South Africa. They can be sitting anywhere. The second thing about it is we find that 80% of the time the nurse can deal with the patient's issues without calling the doctor. So now the patient's only paying 90 Rand rather than the local GP for whatever, 685 Rand. And then when the doctor's needed, because the nurse and the technology capture as much as possible before the doctor logs in, we're only need the doctor for 4 to 5 minutes. So it's a much more efficient use of their time. So even when you need to see the doctor, the cost of the doctor is lower. So this just is a really excellent solution for lowering the cost to care and for increasing the touch points at which you can get GP level healthcare enabled by technology and this network of incredible nurses who weren't being utilized properly. And then from there, we kind of started unpacking, okay, well, what's the bigger problem we're trying to solve here? What are the other opportunities in the space? And the idea with Healthforce was never really just to build a physical nurse with a virtual doctor. It was to build something much more to solve a much bigger problem. Sure. But we explored that problem by solving the first initial issue, which was get something affordable into places where people can't access a GP.
I can tell that you are very passionate about the solution, and rightfully so, right? The numbers will validate why, and we'll get into those in just a second. You were going to say something.
Yeah, I mean, it's an interesting word, passionate. I mean, I do. Yes. I get absorbed by healthcare is a fascinating space. It's this weird nexus of social justice. It's a strange space because it's like no other market, so to speak. There's an information asymmetry always. When our first son was being born, we went to the gynecologist. The gynecologist said, well, did a scan, maybe the baby's got water on his brain. We need to do immediate cesarean section. So in that environment, you always just listen to what the doctor does because of the information asymmetry. And there's nowhere else like that. I mean, if you go into a shoe store, you can look up online, which is a better shoe. Even if it's a car and you don't understand mechanics, you can take it for a second opinion. I mean, that's the one thing in healthcare that differentiates it. The second thing in healthcare that differentiates it is that nowhere else is there $28 billion of spend in South Africa alone, where only a fraction of that is actually paid by the consumer. It's always paid by a third party. It's paid by the Discoveries of the world. It's paid by the government. So there's this weird thing where there's this massive amount of spend, but there's always a third party paying, which skews the way the service is delivered, because now you're getting a service that the funder is willing to deliver rather than what the consumer actually wants. That's the second thing why it's very different. And the third reason why it's very different is that bizarrely in healthcare, at a system level, you get less if you pay more. And you get more if you pay less. And there's nowhere else like that. And so there's this really weird market where healthcare looks the way it does because of this terrible apartheid legacy South Africa has, and it's not a traditional market. And so when you say I'm passionate, I'm more just captured by the problem and the way it allows myself and my team to think in a completely different way about how to solve something that has not yet been solved because of the historical complexities and the unusual nature of the market.
Thanks for listening. We're going to take a quick break. And if you're enjoying today's episode, don't forget to like and subscribe. It really helps us boost our reach. I'm Matthew Marsden, and this is the Startup Club podcast. I'm curious, so how do you go about starting? So you resolve, okay, cool, there is an investor, there is an existing pharmaceutical chain, it would give you distribution, but you still need to build technical infrastructure, you still need to presumably raise some capital to pay said people, building tech. Where do you start, and what do you say the first couple of months, maybe year pre-launch, however long it was, where did you start with Healthforce? You've got this, you now have this inclination, I don't know if it's privied insight, but you do have privied access to this distribution network to roll something like this out. Talk to us about those initial stages of Healthforce 1.0,
sure,
and what that looked like. I mean, if you can take us back.
Sure. I mean, the privilege we had at the time was that the investors that put their money into Healthforce had this investment in these this chain of pharmacies, small to medium-sized pharmacies they were building out called Medicare. And so we had this kind of crucible in which to test and try out what we were doing.
Amazing.
So that was a very fortunate position to be in. I suppose the starting point was really just to spend time trying to understand the nurse, the pharmacy, the pharmacist, and the people coming into those pharmacy. So traveling around to these pharmacies and talking to those people, getting a sense of, like, through conversations, not validating ideas, but asking questions to understand what was needed. I think it was quite risky to go in with an idea that you want validated, because then you try and see what you want to see.
Good wisdom. Yeah, there's bias there, sure.
Then what really helped with that, the second thing was starting with, not starting with engineering, not starting by building something, taking that a step deeper and starting with user experience research and user experience design. and my partner Joe is a user experience designer. So I had that drummed into me. I had that insight from the home environment, and I found what I consider to be two of the best user experience designers in the country, and got them involved right at the start. And they helped to ask the questions in the right way and to start designing something that would answer the problems as they had learned about them through those formal exercises of user experience and user research, user experience design, user research. So I think that's a really another critical part of the starting phase.
Sure.
And then the other part of the starting phase is just to kind of, like I do generally, just put my head down and go, like realizing that I both had to do business development. I needed to be the product manager. I needed to take the trash out. I needed to raise the funding. I needed to manage board and shareholders. So I had to do everything. And I think that I actually quite enjoy it. I like doing lots of different things.
Sure.
But I think, that's another part of the founding, is that you just have to do everything. I suppose that's probably the kind of the key takeaways from those early months.
Good synopsis. Tell me, obviously this is 2018, 2019, 2020. What does validation start to look like? Presumably now this informed build to the research, to the UX elements, UI UX elements. What is when do you know, okay, we're onto something here? Is there a point in the following year, 2 years? Of course, this is just preceding COVID as well, where I'm sure telemedicine and virtual health consults and those sorts of things really have to take an uptick, presumably. Talk to us about when you that the F word, fit, if you would. You felt you reached it.
Sure. I mean, that's an interesting question. Look, this was all pre-COVID.
Sure.
To be honest, to this day, I'm not sure that we found fit. Okay. I think that I'll come back to that, because there's a demand side problem that every creator of healthcare products, whether they provider products or funder products, experiences in South Africa and probably more broadly in other private markets around the world. Yes. But at the time, what gave us the sense that we were onto something was when we figured out how with Medicare to unlock the ability for their leadership and their nurses to want to call the doctor. And it was a big shift in the mindset. And this is the first time, remember, in South Africa's private sector outside of a hospital, that a nurse and doctor were working together as a team. And it was a new way of delivering healthcare when healthcare providers are traditionally quite conservative in doing things in a new way because they're worried about legal risks. And where patients are nervous about doing things in a new way, especially when they're feeling sick and they just want to be treated in the old way in which things were done. And there was this period of time where we figured out, okay, cool. We had to do this in partnership with the Medicare leadership. Okay, here's a way we're working in partnership together. We're able to unlock growth.
Interesting.
And through that, we were then able to kind of demonstrate to other pharmacies outside of Medicare that there's some numbers that show we can do this, and we're able to apply the same kind of partnership model that we had with other pharmacies to new pharmacies. Sure. And then I suppose there was a moment where Dis-Chem took a look in particular, and they said, well, Dis-Chem's got a phenomenal network of nurse-run pharmacies where they really invest in providing qualifications to their nurses and building out more than one pharmacy per store. And they're really going deep and providing primary healthcare in their pharmacies. And they took a look at what we were doing and they said, okay, this is the next evolution of what we want to see in our pharmacies from a primary care perspective, and agreed to a rollout. And I think that was end of 2019 where we knew, okay, end of 2019, we're starting to implement with Dis-Chem. We're going to reach scale here. That's, I suppose, the point where we no longer felt like we were fighting for survival.
Just to fuel some of this growth, did you raise additional capital in that 2-year period once you found that kind of fit and to support?
So we're fortunate. I mean, it was a battle because you know unlocking capital when it's someone's money is hard. They want to know their money's going to the best place it possibly can. But the initial 2 investors that we had were willing to fund us through that period.
Brilliant.
And so we didn't have to bring on any other investors. And we went through this period where we started rolling out with Dis-Chem, and Dis-Chem started taking a very strong interest in what we were doing. We showed we could deliver. We showed our technology worked. We showed we could deliver an exceptional doctor experience. We showed we were, in some senses, a culture fit with the way Dis-Chem operates and the way Dis-Chem wanted to deliver healthcare. And we started to see the door open for an opportunity for Dis-Chem to provide us the capital to scale. And that's really where
sort of the dream, to be honest,
capital scaling element came in.
Okay, excellent. Presumably COVID only 10x's all of this, right? Is that a wrongful assumption?
The wrongful assumption,
so please expand then,
Well, you can think during a COVID, people don't really want to go into a shopping centre and certainly not into a crowded pharmacy to get access to healthcare.
Okay.
So, look, the reality was that the regulations before COVID only allowed telemedicine healthcare to happen with a patient that you haven't seen before, if there was another health provider in the room.
Okay.
So the model of the nurse in the room with the patient and a new doctor seeing that patient was allowed. But at the time, that doctor was not able to talk directly to the patient unless that doctor had previously seen that patient.
Oh, wow. Okay.
So the regulation didn't allow for what COVID really needed, which was stay at home and we talk to you there. During COVID, the Health Professions Council changed the regulations temporarily to allow for that and subsequently changed it permanently. And so what we saw with Healthforce is that, like with all other GP consultations, things dipped during COVID because people just weren't, either they weren't getting sick because they weren't going into public environments and putting their same, I remember at the time we were working in WeWork, and WeWork prided themselves on these bowls of cookies that everyone could share. Post-COVID, you look at that and you think, what the heck were we doing, So those environments weren't there during COVID, so people were less sick, and then also people were more scared to go out and get treatment when they were only a little bit sick and they rather looked after themselves at home. But it really was on the back of that change in regulation that allowed us to start thinking about the second company that I founded, which is Kena Health.
Which is Kena, yes. And I think that's a great segue. We'll perhaps get into some of the stats around Healthforce in a couple of minutes, because as far as as at least from a layman's perspective, the stats would suggest strong validation of the Healthforce model. But as you mentioned, there is now another need that arises, and it's more in the telemedicine space. It's more in the direct consult between doctor and patient space, perhaps an adaptation on the back of these eased regulations. 2021, you co-found the Kena Health app. And, most founders probably wouldn't have the capacity to run more than one startup at once. So I think that's pretty impressive. It might have simply been what the situation called for, and it was what it was. Talk to us about spinning out an independent venture.
Sure.
And, couldn't this have just been a feature perhaps of the Healthforce proposition? Why did you think to launch an independent venture and now become a CEO of a second business? And again, this is... I think it's also just with caveating that, from what I understand, you'd introduced a preliminary telemedicine play at Healthforce in 2020. And I read you had over 100,000 consultations via that process.
Well,
so
actually,
you had maybe some testing of the market?
Well, Healthforce has always been bricks and mortar, caller and a virtual doctor.
Augmented with tech, correct.
And the numbers there, as you mentioned, they were looking good. So I say there's no product market fit because I'll come back to the product market fit problems we still have today, but we unlocked a significant portion of growth where we reached 3.5 million. We've today 3.5 million nurse consultations done in our enabled clinics, and I think by numbers I haven't seen anyone delivering more telemedicine services through that virtual doctor to physical nurse anywhere on the continent. I've lost track, and we're probably up to 250, 300,000 telemedicine consultations delivered. So that's the telemedicine experience we had. And Healthforce, in all honesty, today doesn't just do that clinic-based. We're actually building a bunch of other technologies that are, again, physical technology infrastructure that's used in a team-based environment in bricks and mortar stores. We haven't launched all of it yet. Some of the stuff is in beta, or some of the stuff is still under development. But the idea with Kena was to say, well, we've figured out how to deliver. Look, Healthforce's NPS, for want of, NPS is an imperfect measure, a net promoter score. We'd figured out a really good service offering through our telemedicine. The average NPS for healthcare in the US, for example, sits at 5. The highest NPS I've seen published in South Africa is around 36. I think it's 36 for Bonitas, which is actually a funder, not even a provider. And we're sitting at a Healthforce NPS of 78. So we delivering at scale, delivering really exceptional quality.
Yep.
We'd learned a bunch of lessons technologically, from a clinical service perspective, from a customer success support perspective. And the idea now was, well, let's take this to purely virtual. Instead of the nurse being in the bricks and mortar clinic, let's take the nurse into a purely virtual environment and still allow the nurse to work as a team with the doctor in a way where the nurse does as much as possible. The doctor's only needed as necessary. And let's also bring in not just physical health, because now we've got this virtual environment, we can bring anyone in. Let's start bringing in this other part, this mental health aspect. Because so often in Healthforce, we're seeing people struggling with physical issues that were a symptom of mental health issues or were creating mental health issues. And similarly, I know from the mental health space, from talking to people who work in that space, there's a lot of ways in which mental health manifests in physical ways, or in which physical ways manifest in mental health ways that needs treatment. And the reason why we didn't start that in Healthforce is because it's a different customer. It's not the customer that's walking to a pharmacy. So it is a different product in that sense. And then also because the investors that we had in Healthforce really wanted to double down on what Healthforce was doing in the bricks and mortar plus virtual play. And yet, despite that, there was still this strong need to build out an ecosystem to solve the bigger problem that we were starting to see. And maybe this is a good time to talk about what that bigger problem is, and then you starts making sense why Kena is necessary and all the additional things we're building in Healthforce are necessary. So, look, the need to deliver low-cost care was at the heart of the founding of Healthforce right at the start. But let's just unpack what that actually looks like in terms of South Africa. So in South Africa, only 9 million out of 60 million South Africans, it works out to around 16% of the country, can afford private healthcare. The remaining 50-odd million people, 80+% of the country, relies on government. Either they rely entirely on government services, or they at least rely on government services for expensive healthcare, any hospitalizations or chronic medications. They can pay a little bit maybe out of pocket to go and see a nurse in a clinic, or maybe they can pay for a GP as well. And so you've got this environment where government is really struggling to deliver, because they're struggling from a budget perspective, from a management perspective. Having worked with government through AHP for over a decade, I could see that system was taking massive strain and wasn't delivering quality. And yet those people couldn't access these really well-resourced environments because it simply was too expensive. The question then became, why is it so expensive? And we took a look at that. And really, when you get down to it, there's a number of reasons why. The traditional reasons that are quoted for really expensive private care is things like aging populations, which require obviously more healthcare, things like technology in the private healthcare space, like CT scanners or whatever other new technology coming in is more expensive. Healthcare ends up becoming quite much more expensive. But really at the heart of the problem of expenses in the private healthcare sector is fee-for-service, which is a model where you pay a provider. That provider might be a doctor or a nurse or a hospital. You pay the provider for delivering a service, not for delivering an outcome. Nowhere else does this happen. So again, you've got this weird market. This is coming to that point I made earlier about you pay more and you get less. Nowhere else does it happen where you're spending as much as you do, and you pay the money whether you get what you wanted or not. So it's like saying to, going and taking in your car for a service, and the guy takes a look and says, look, I've done the best I can do. It's not quite working. You owe me 10,000 Rand. You'd laugh at the guy and go like, what do you mean? I'm not paying for something where you haven't done your job. Yet we go to doctors, and they're very well-meaning doctors really trying to deliver services, hospitals really trying to deliver good services, and we pay those providers irrespective of whether they deliver or not. And unfortunately, that creates incentives in the healthcare system to either over-service, do more than what's necessary. It creates incentives to fragment the system, where I earn money from you as a patient in a particular hospital. I'm not going to refer you to a different hospital group who are specialists to deal with your particular issue.
Could solve this, right?
You could solve this. I want to hold on to you and the revenue you're giving me as a patient. So it creates fragmentation in the healthcare system, where when you go to that new hospital, records aren't shared and things get missed, and that becomes more expensive to care for you. And it creates duplication, because when you do move, for example, from your GP to a pediatrician, that health record's not shared, the pediatrician for your child might end up repeating the same tests that were done previously by the GP. So there's duplication. So there's duplication, fragmentation, over-servicing, drives up cost.
I have to say that I think every person in the audience here is going, oh yeah, no, I've experienced that. Or I know someone who's experienced that.
Absolutely.
So you're bang on the money.
And that's what's driving up costs. And look, again, there's not evil providers. It's just, there's an incentive in the system to deliver healthcare. And every doctor needs to make a living, but particularly if you think of where healthcare is delivered by the big hospital groups, they make up 83% of the beds in the country, Medcare Life and Mediclinic, and they each make between 3.5 and 4.5 billion rands with a profit a year. And their incentive listed on the JSE is to deliver shareholder returns. So they've got to keep growing. And so the incentives in the system are such. And the history of that is quite interesting because the reason why, if anyone actually wants to read more deeply about this, the best place to start is to look at even just the synopsis of the health market inquiry done by the Competition Commission published about 2 years ago. It really unpacks this in a lot of detail. But really, what's happened is we've got a very unregulated environment. And the reason why the environment is so unregulated is because at the end of apartheid, when Nelson Mandela and his transitional government were coming in, they thought there would be some degree of social solidarity. They thought that up until that point, everyone had used the government system. It's just that white people had the Chris Barnards of the world and black people had absolutely nothing. And the idea was that white people would keep using the government sector, pay for those services with all the money that they had, and they could use those funds and taxes to uplift other parts of the healthcare system. And so they didn't predict and didn't regulate for the establishment of a parallel private sector, which is essentially what white people did. They scared that their precious healthcare was going to get taken away. They paid for the establishment of the likes of a Discovery and a Netcare and all the other big private healthcare institutions we see today. And they're operating a relatively unregulated space with profit maximizing incentives, as any listed company has, still trying to do the best for their patients, of course, but always with this drive in the background that they need to deliver shareholder value. And so we're in this position where in a fee-for-service environment where big listed companies are trying to make profit, that they are trying to drive healthcare that delivers profitability, not necessarily best healthcare for the patient. So if you look at healthcare from that perspective and you start thinking what the problem is that healthcare is not being constituted based on what the patient needs. Healthcare is being constituted based on the way the system has been set up based on a bunch of incentives that haven't been really thought about properly. And so now you take a step back and you go, okay, well, what does it actually mean to, what is actually required to make someone healthy? And you think about the units of professional time, for example, that needed for that. How many units of doctor's time, of nurse's time, of gynecologist time, of pediatric time, how many units of this time is actually needed to get that person from sick to healthy? And I don't just mean rationally giving them the medicines, but also emotionally making sure that they feel comfortable, that they're cared for. Right? How many units are required? And you start realizing that the actual units that are required, when you sum them up, come to a lot less than the rand value that's being paid. And so the whole idea from that perspective with Healthforce and with Kena is to reconstitute the healthcare delivery experience for a patient in such a way that it's both better and uses as few of those units as possible, either because technology does more, or nurses do more, or GPs do more than gynecology, reconstitute in such a way where it's a much lower cost experience. And although we can't change the incentives in the system right now, even on a fee-for-service model, we can change the internal incentives amongst our own team of clinicians, so they incentivize around patient experience and working as teams, and we can reconstitute it in a way where we use the minimum amount of units to give you the best possible experience, and that's how we lower the cost of care, and so and deliver better experience at the same time. So you can pay less and get more. And that's really where Kena was born from. Can we do that in a purely virtual environment? It's a long explanation, but that's essentially what we're trying to do.
But I think for the benefit of the audience, probably more context on the healthcare dilemma and perhaps a route forward than they have deep dived into probably ever. I know I consider myself slightly wiser for hearing all of that. And you're really putting that into action. You're lowering the healthcare cost to 185 Rand a consult through a Kena Health.
And 120 in some circumstances.
120 in some circumstances. You know, that's down typically.
And it's actually getting even less than that.
Which is unbelievable. I'm keen to talk very, very quickly about the actual process of spinning this out. if you don't mind. So again, we've got a health force. We identify this other gap. Now we want to spin out this telemedicine play. It's more of a direct-to-consumer play as well. And this is where Kena is coming from. How do you actually go about building that business, noting that your time, your focus, your current funding lines are devoted on an existing business? I'm curious. Help us navigate that initial pivot, if you would.
Sure. So actually, before Kena, we did mock up a few direct-to-consumer apps. We explored with our shareholders at the time, majority shareholder at that stage being Discam, what those look like. For all the reasons I've described, no real appetite there, but we had this thing in the back of our minds. Like, we know the ecosystem needs the physical point of care with the nurse, because the nurse can do a lot more physically, but there's definitely a space, given what we're seeing with the physical nurse, that could be done purely virtually. And, as you said, I was calculated. I'm not calculated anywhere. I come across...
People might disagree based on that explanation, but...
Well, what I do, and what my team does, and what I've been fortunate enough to do, is to have other people who these aren't my ideas, right? They're other experts in the space, some people who I follow and read, some people I know who've really helped with the thinking, joined the organization for periods of time. But really, this whole thing is a function of always trying to go back to first principles and ask, what's really going on here? Model reality in some way, rather than analogize what a GP consult looks right now and turn it into a virtual. We're never trying to do that. So really what happened, and correct me if I actually might have forgotten the question, but what happened in this kind of transition phase is that we knew that there was a place in the ecosystem that we saw was needed for a purely virtual play, lower cost because you're not going bricks and mortar, better reach, and so on.
So how do you spin that out?
The universe delivered at that time a reconnection to somebody that I'd known previously, who had a contact with a Swedish venture capital firm called Webrock. And what Webrock was doing was they were taking really awesome technology from Sweden and starting companies based on those kind of products in Sweden in Brazil. And they were interested. They had a really interesting play that they'd made in a healthcare space in Brazil, and they were interested in maybe doing something in South Africa. And this guy who's now the chairman of our board connected Webrock and Healthforce. And Webrock said, cool, we will bring the funding and some experience that we've got now from this company in Brazil. Healthforce said, great, we will take the lessons we've learned, the back-end tech we'll share with you, the lessons we've learned around clinical delivery and the customer experience there, how we deliver telemedicine services, customer success, and so on. We'll even leverage our leadership. So at the moment, Kena and Healthforce, while they're separate teams, they share COO, CTO, Chief of Staff, CFO, and CEO. So we'll share leadership, and we'll form this new company that will take the best of Healthforce's experience, the best of the Brazilian experience, the funding from Webrock, and we'll establish this new entity called Kena, and that's really how Kena came about.
Unbelievable. It's been an amazing 2 years, seemingly, for Kena, and we'll get back into whether you found fit in either venture. But in 2023, the app reached more than 300,000 downloads, delivered over 25,000 patient consultations. 35,000, excuse me. You also raised an extension round for the business, a few $1 million from the likes of Next 176, which is a venture arm out of Old Mutual. And you won the MTN Business App of the Year late last year. So one might suggest that is positive traction, or even some sense of validation. How are you feeling about, and maybe this is a good way just to sum up where you're at as Saul, the founder of both these ventures right now. How are you feeling on both fronts, given all that's happened in a very short space of time?
Yeah, so that sounds like a lot of stuff has happened in a short space of time, but really the fact that MTN decided we were the app of the year means nothing unless we're actually delivering low-cost healthcare to as many of the 50 million South Africans in need as possible. So look, I don't want to diss them. They've done an incredible amount for us. But it's not a lot for us until that lot translates into actual people using. Exactly. And so when you talk about 300,000 downloads, it's also 350,000, close to 350,000 downloads now. And you talk about 35,000 consults. Again, if you look at what we're trying to do, it's a drop in the ocean. So I feel like we still have some distance to go before we find real product market fit.
Okay.
I feel like we've learned a hell of a lot, and it hasn't cost us too much because we've failed in multiple areas, done things wrong in so many different ways. Fortunately enough, at this stage at least, those things haven't cost us so much that we don't have a business.
Sure.
And now we've got that wealth of knowledge. And then the other thing we've got is, I feel like we sit on the cusp of something that has massive potential. And that massive potential, unfortunately, I can't talk about, but we've got some really huge opportunities and partnerships in the pipeline. And so I suppose as the founder of Kena, I'd say we're still grappling, but we sit on a massive amount of potential that still needs to be realized. And I'd say on the Healthforce side, probably something quite similar, but just further down the line.
Okay. I think I probably speak on behalf of all the audience that given all of the context to the solutions you have now built, and all of this, I mean, this is almost 2 decades worth of time in the space and availing yourself of experts and resources. And I've met some of your team. I've had the fortune of meeting a number of them, highly competent, highly passionate again about solving this core problem. I know I'm really excited to see what Kena does next and Healthforce does next. And I think one of the questions I wanted to ask you is, what are some of the short-term prospects that folks can look out for without getting into anything that's too privy or can't be disclosed? You know, talk Kena in 12 months. What are you hoping at least both ventures might achieve?
Sure. Let's start with Kena.
Sure.
Look, again, you mentioned this word passionate. My team is passionate, but again, it's a low ego team because we always focused on the problem we're trying to solve and trying to ask the questions to understand the problem better. And so the passion comes from a real connection in a relatively, because there's always ego involved, but in a relatively less ego way. Sure. Okay. And yeah, we do hire for competence. So yeah, I'm glad you've appreciated that. But yeah, we can always do better. Kena in 12 months. I suppose there are 2 sides to the Kena puzzle that we need to solve. I still think 185 Rand is too expensive. I think 120 Rand is too expensive. And we've got a number of things in the pipeline where through partnerships, we think we'll be able to offer these services at maybe half the current price.
Amazing.
And still have a viable business. Right. So that's kind of one thing I'm hoping in 12 months' time. Some of the things I can't talk about, but I'm hoping that a large chunk of South Africa, and I'm talking about the price point. Yep. Then the second thing is I'm hoping that a larger chunk of South Africa has become aware and become educated and finds credibility in the service, so they're willing to try it out. And I'm not talking about a larger portion of South Africa, like another 10,000 people or another 500,000. I'm talking about 10 million, 20 million people. That's where we want to get to. Maybe not in 12 months, but certainly that we're on the pathway to, because we can't serve all those people right now, but we're on the pathway to being able to see where 10, 20 million South Africans will want to use us. Sure. That's from a kind of a customer perspective. And the third thing is to say that we've got a much clearer idea on the prioritized product features that need to get built that our customers actually want to allow them to engage in a healthcare service we know they need. So as I mentioned previously, there's a demand side problem in healthcare. You've got lots of funding products being built, lots of really awesome tech out there, some incredible tech around women's health, like Zoe Health won Zoe who won yours. Right? An incredible app for women's health, and there's guys that do mental health, like Panda Health and whatever else, like really awesome tech out there. But everyone's facing this problem of we built something, we know when you use it, you love it, we know you need it, but why aren't you using it, right? And so
the founder's dilemma.
In healthcare specifically, and all founders, but healthcare, because it's not a usual market, is particularly difficult. But I'm hoping the third piece, the product piece, allows us, that we've got a good enough understanding of our customer and what our customer needs, that we figure out how to unlock that demand. Okay. Not just through the partnerships that are going to expose us to 10, 20 million people, and not just through a price point, because ultimately you can lower the price. It doesn't mean people are going to buy you, but really understanding the customer and what we need to do for that customer to get them using this thing as the critical piece of their healthcare.
Amazing. Okay. So we've got a couple of minutes left, and so I just want to ask you two final questions before I let you go. And this has been most informative. I don't think I've had such a deep dive, like I mentioned, into the healthcare space, but also the very practical route to potentially solving some of those core gaps. It's wonderful privy to insight. Two questions that I like to ask of each founder we have on the episode. And again, we've got a large founder contingent that listens in on these podcasts. Those are folks that have existing businesses or post-product, post-raise, some of those who are thinking about starting something. They've got an idea in the back of their mind. You would be approached, I'm sure, by a number of said founders and probably ask for advice. At the same time, you're an observer of the tech ecosystem and see a lot of founders founding a lot of businesses. If you had a platform like this to give founders perhaps a piece of advice or one or two pieces of advice that you see are just common mistakes people make over and over again, or maybe undervalued elements of the founding journey, what would you speak to to an audience like this, or on a platform like this? What would you probably say?
I'd say that I don't know what the hell I'm doing, and that it's okay if you don't.
Yes.
And actually, for as long as you can hold on to that mindset, probably the better off you'll be. The worst thing you can have is certainty in anything, because at that stage you're probably going to stop asking the right questions. That's the one thing I'd say.
Okay.
I genuinely don't know. I genuinely don't know answers for things like, how do we unlock the demand side problem? How do we better reconstitute the service for better experience? I don't even know what our product is going to look like in 12 months' time. So I think not knowing is the one thing. The second thing is, just from a founder's perspective, is the cap table. We've spoke about this earlier, and I know you've had your personal experiences perhaps in the space too, but like, if you don't get your cap table right from the outset, you can spend your whole time as a founder just managing the implications of that. And there, unfortunately, you're not going to read anything in a textbook that's going to help you. You have to look at your particular situation. You have to speak to people who are in similar kinds of situations and get advice from them. And that would be the second thing.
Okay. Powerful wisdom, because I think folks are so keen to raise in a capital inefficient market that they'll take any terms, right? But it really can completely reconstitute what this business does, becomes where you go as a founder. It's a very, very good wisdom. The last question, and this is maybe just some privy insight into where Saul might go, that we ask all of our founders is what does success look like for you?
Personally.
For you personally, Saul Kornik, you are 80 years old one day, sitting on the patio in your rocking chair. What does success actually look like? For some folks, it's generational wealth or accumulating, big home, or I don't sense that's probably the primary motivation given the nature of the work you do. But, what would you look back on and go, that was a pretty fulfilling and successful life?
If my sons want to phone me and want to come visit me without prompting, I'd say I'd probably be pretty happy at that stage.
pretty profound.
But from a kind of a business organizational development perspective, two things. One thing is that I created an environment where people could really thrive. That doesn't mean they're always happy. It doesn't mean they're always comfortable, but certainly a place where they can thrive.
Sure.
And then secondly, that I have personally kept focus on the problem to be solved and not got distracted by either shiny things or the places you go when you get frustrated that can be driven from places of fear or places of ego and wanting to be recognized.
Powerful. And obviously the third is to land a rocket on Mars.
I think at this stage, if I can get to the moon,
there we go.
That'll be fine.
That's fair. That's fair. Saul, thank you. I think I've thoroughly enjoyed our conversation. I'm sure that the audience resonates with that, and really just getting these insights into your journey, into the business, into your privy position to attack this problem. I'm pretty sure I speak on behalf of most folks that we're excited to see where the businesses go next, and importantly, what's next for you. So thank you so much for joining us today. It's a wonderfully humbling opportunity. And of course, we wish you all the best.
Yeah. Thanks, Matthew. Thanks for having me here.
Amazing. Thank you so much for listening to today's episode. That was Saul Kornik, co-founder and CEO of Healthforce and Kena Health. I'm Matthew Marsden, and if you enjoyed today's episode, please be sure to subscribe to our channel, follow us on our socials, and share with your network. We'll see you next time.